Today's topic is about the newer kids in anemia management, that is the HIF-PHI inhibitors. They have been there since 2022, but even then, a lot of them are not confident of using it, or means they are hesitant to use it because of the so-called perceived side effects. So let us see, means whether they are really true or whether it is only means mind games what we are playing with them. So I would be dealing with the current guidelines, means the consensus regarding his PHIs and the controversies and the practice points what we need to know. So this is what we all know. As the stage of CKD goes up, the prevalence of anemia goes up, and so does the requirement for ESAs. And we all know that the anemia in CKD is multifactorial. So we have got reduction in erythropoietin production, reduced responsiveness to EPO, reduced iron levels by reduction in GI absorption. Blood loss will be there because of repeated dialysis and phlebotomies. Reduction in the erythrocyte survival, and there is an associated inflammation which is going on in the CKD. So what does the ISN guidelines say? So this is the ISN guidelines 2025, of which Dr. Satish, who is currently here, was a part of. And what they say is whenever there's a hemoglobin of less than 13 grams per deciliter in males and less than 12 grams per deciliter in females, you have to consider the possibility of an anemia. If there is no anemia in CKD, you need to look at the concentration, HB concentration every 12 months in CKD3, every 6 months in CKD4, and every 3 months in CKD5ND and 5D. Once there is anemia, we need to monitor them quite frequently, whenever clinically indicated, and at least once every 3 months in CKD 3 to 5 non-dialysis, and once a month in patients with CKD 5 dialysis. And once you establish that a patient has got anemia, and once the hemoglobin is less than 10 gram per deciliter, you need to start them on ESA therapy. Before that, you need to address other factors like iron deficiency, vitamin B12, folate deficiency, and correct if there are any active infections. So the target HB level has been a bit liberalized now. It is 10 to 12, not the 11 to 12 was described earlier. And the selection of ESA therapy should be based on the local availability, the finances of the patient, whether the patient can take injections or oral tablets, and the clinical response and the patient preferences. So a bit about iron therapy in CKD 3 to 5 and the CKD 5 PD. We can initiate oral iron, but in dialysis patients, it always IV iron. And whenever the ferritin level is less than 700 and TSAT less than 40%, we need to start them on IV iron administration. And use IV iron with caution if the ferritin is more than 800. Regarding ESAs, I won't be dealing with them here. So we can use either the conventional erythropoietin, the dabipoietin, or the CRAS. So all three are good, very effective molecules, and depending upon the patient profile and your facilities available. So HIF-PHIs are newer molecules. In India, it has come into the market since 2022. So they can be used as an alternative to injectable ESAs in CKD 3 to 5 patients who do not have any easy access to storage and refrigeration for ESAs. But nowadays, a lot of patients are themselves coming and asking us for HIF-PHIs, and they are not keen on having injections. And in whom it should be avoided is recent malignancy, recent cardiovascular events, polycystic kidney disease, proliferative diabetic retinopathy, PH, and pregnancy. So we'll see in detail whether all these fears are true or not. And a trial of HIF-PHI may be considered in patients with CKD anemia and ESA hyperresponsiveness who do not have any contraindications to use these agents. So this is the gist of the ISN guidelines 2025.
Suraj sir, before proceeding forward, can we put a pre-test poll and see how?
Yeah, okay.
Kaushal, can you post the first poll? Kaushal? Okay, okay, we can end poll. Can you post the results? Okay, our nephrology community is very confident. Can you post the next poll also, Kaushal? So what are your concerns regarding Desi-Desidustat? Do you think it is not effective? Or is it okay? There is one more question in the bottom. You can answer that also. Okay. Can you post the results? So most of them are concerned about the malignancy risk associated with HIV inhibitors. And regarding Desi-Desidustat itself, uh, we have divided opinion. So we'll see how Suraj sir's talk will influence our listeners. Suraj sir, please go ahead with your further presentation.
Yeah, you can. Can you close the poll window, Kaushik?
I,
Yes, sir, it is closed.
you can close it also. Yeah. Yes, sir. Your slides are visible. You can continue.
Yeah, okay. So in the KDIGO 2024 guidelines, so what they said was you can use HIF PHIs, not as the first line, but if you're suspecting hyperresponsiveness, you can use that. So if you look at the history of HIF PHIs, a bit of it was told by Dr. GK. So in 1977, erythropoietin was purified from the urine of patients with aplastic anemia. In 1985, the erythropoietin gene was cloned. So in 1995, Greg Elsemensa, who got the Nobel Prize in 2019, he discovered the HIF transcriptional complex in 1995, but they felt that something else was lacking, which improved the hemoglobin and which dealt with the oxygen sensitivity. The VHL gene was described by William Kael Jr. And ultimately, three of them got the Nobel Prize in Physiology and Medicine in 2019. In 2019, roxadustat was approved in the US, but then we will see what all issues they had with roxadustat. In March 22, Desi-Desidustat was approved by the DCGI India for treatment of anemia of CKD. So this is an overview of the HIF metabolism. So there is a continuous HIF synthesis which is going on in the body. So usually it is hydroxylated by the prolyl hydroxylase. There are three PhD1, PhD2, and PhD3. So this by the end product is ultimately undergoes VHL mediated polyubiquitylation and proteasomal degradation and gets metabolized. Whenever there is a hypoxia, this HIF there is an inhibition of PhD1, 2, and 3, and this HIF alpha undergoes nuclear translocation. So there is an increase in erythropoiesis, energy metabolism, and the pro and cons of HIF occurs. So basically, there are HIF1 alpha and HIF2 alpha. HIF2 alpha is the good molecule. So there is a cardioprotection and renoprotection, and it improves the erythropoietin synthesis. But HIF1 alpha is the bad part. So it causes an increase in the cardiovascular events, increase in cardiac, vascular, and renal inflammation and fibrosis. So this is an very interesting thing. So when you add a SGLT2 inhibitor along with the HIF-PHI inhibitor, so what happens is it inhibits the HIF1 alpha and improves the HIF2 alpha. So there is a potentiation in the erythropoietin effect, and there is a reduction in the bad products. So ultimately, adding a SGLT2 inhibitor to a HIF-PHI is beneficial. Is beneficial if you look at it clinical wise. So what HIF does is there is an increase in the DMT1 and it inhibits hepcidin. So there is an increase in the ferroportin expression. So it helps in the absorption of iron from the intestine and mobilization of the macrophage ion. HIF improves the transferrin and transferrin receptor. So there is an increased iron transport to the bone marrow cells. So by lieu of it stimulating the erythropoietin receptor and increasing the EPO concentration, there's an increase in erythropoiesis. So HIF-PHIs activate the HIF pathway, and there is a coordinated response, both increase iron availability as well as an increase in erythropoietin. So that effective erythropoiesis occurs in the presence of physiological levels of erythropoietin. So Desi-Desidustat is Desi-Dustat. Desi means Indian. So ultimately it is the Indian HIF PHI, which was developed by the Zydus Life Sciences. So earlier they had an agreement with the China medical system, but ultimately it didn't take off much. In March 22, it got approval in India by the DCGI for treating anemia associated with CKD in both dialysis and non-dialysis dependent patients. In October 2023, then there was a co-marketing with Sun by the brand name Rightstat. And again, 2024, there was a renewed interest in China and it was accepted for review. In February 2026, FDA granted the orphan drug designation for beta thalassemia and sickle cell disease. So this is the story of Desi-Desidustat so far. So this is the structure of the various HIF PHIs which is commercially available. So if you look at Desi-Desidustat, it is more of a flat molecule.
Hello.
There are not many.
Hello. बेटू ऊंचा ना एक मीटिंग में
Kaushal, Kaushal, please mute all. Yes, sir. Please proceed.
Yeah.
Please.
So Desi-Desidustat is more of a flat molecule. There are not many side chains, etc. So the advantage is there are not many byproducts, and ultimately it is a very stable and a quite safe molecule compared to the other HIF PHIs. So this is the pharmacokinetic profile of the various HIF PHIs. So roxadustat is the classical and the first introduced one. It has to be dosed twice a week. The absorption is about 40 to 80%. It is metabolized mainly by CYP and the UGT1 systems. And it is not excreted in the urine. The half-life is about 8 to 21 hours. However, it had multiple drug interactions with phosphate binders, ion preparations, then HMG-CoA reductase inhibitors, probenecid, and gemfibrozil. So coming to the others, daprodustat and vadostat, and they are not available in India. So they have to be taken daily. So that is one drawback. The half-life is almost same, about 1 to 7 hours. They are also primarily metabolized by the liver, and they have got potential drug interactions with many medications. So Desi-Desidustat, it is an Indian molecule available in India. The dosage ranges from 25 to 150 milligram, and it is given thrice a week. And it has got a predicted high oral availability, so almost 100% bioavailability. And it is not metabolized by the CYP450 enzymes. So it is available in a steady state in the liver hepatocytes. And about 28 to 41% is excreted in the urine. The half-life is 7 to 11 hours. And it doesn't affect the Indian transporters much. And there is no significant clinically relevant drug interactions. So it can be used, but then the ideal time to be taken is 2 hours after a meal, and there has to be a gap of 1 hour between the next meal. And it doesn't interfere, or there is no interference from phosphate binders or others. So we'll come to the controversies. So the first is Desi-Desidustat effective? So we have seen from the poll that almost everybody knows that Desi-Desidustat is effective, but then a lot of them are skeptical that whether it is effective alone or you need to piggyback it with another ESA. So this was the initial HIF PHI consensus document recommendation. This is from the South Asia guidelines for HIF PHIs, which was published in 2023. So what they felt that when you offer Desi-Desidustat, they have to be thoroughly explained regarding the potential benefits and harms, including the very low certainty of evidence on its effectiveness. They were also not very sure that if PHIs were effective initially, but then later the story changed. And as usual, they have to be replete with iron and other vitamins before you start them on Desi-Desidustat. And again, it was presumed to be less expensive than the ESAs. So then came the two landmark trials, the DREAM-D and the DREAM-ND trials. So the first one was the DREAM-ND trial. So both of these were published in the American Journal of Nephrology by Agarwal et al., one of the doyens. And both of them proved that they were very good molecules for hemoglobin improvement. So this DREAM-ND was a phase 3 multicentral open label trial. So the study population was 18 to 80 years, CKD 3 to 5, who were not on dialysis, who had a hemoglobin of 7 to 10. And they compared it with the dabipoetin over a period of 24 weeks, and the target range was 10 to 12. So at the end of the trial, there were similar numbers in Desi-Desidustat and dabipoetin alpha, and the hemoglobin rise was more or less the same, and it was non-inferior. So you look at the secondary endpoints, the time to achieve the target hemoglobin was more or less comparable to dabipoetin. The percentage of people who responded to both were same. However, there was a significant reduction in LDL-C. There was a reduction in hepcidin. And if you look at the VEGF levels, there was no significant change. And both of them were equally safe. There was no variation in the serious adverse events. So you look at the anemia parameters, the rise in hemoglobin almost mirrored each other. The serum iron was more or less the same. Ferritin again was the same, and the TSAT percentage was slightly better in the Desidustat. And this is the DREAM-D trial. So they looked at patients who were on dialysis. Again, it was a phase 3 multicentral open label trial. But here, what they looked at, what the molecule what they compared was the erythropoietin, because it was easy to administer erythropoietin for a dialysis patient. So you look at the primary endpoint, 392 patients were enrolled, and the numbers were almost the same. At the end of the study, the hemoglobin rise was non-inferior. Both were almost equal. But if you look at the time to achieve the target hemoglobin, those who were on Desidustat, they achieved the hemoglobin targets much earlier compared to erythropoietin. And the percentage of hemoglobin responders were better in the erythropoietin, were better in the Desidustat arm. Again, LDL-C was better in the Desidustat arm. The hepcidin was lower. And regarding the VEGF, there was not much difference. And the adverse events were more or less the same. So you look at the hemoglobin response. So this is what is very interesting. So this is an advantage as well as a disadvantage. Advantage because you get a very rapid rise in hemoglobin. Patient is very happy. Disadvantage because it is your nightmare, because you always have this airy feeling at the back of your mind that whether the patient's fistula is going to close or whether they are going to have any cardiovascular events, etc. But for the patient, they feel good because their hemoglobin was gone up very fast. And you look at the ferritin, it is lesser in the Desidustat arm. And you look at the TSAT, again, it is more in the Desidustat arm. You look at the adverse events. In the non-dialysis patient, edema was more in the Desidustat arm compared to the dabipoetin arm. And the hypertension was lesser in the Desidustat arm compared to the dabipoetin arm. Again, this is very interesting because EPO can potentially increase your blood pressure. And you look at the dialysis group, and again, the side effect profile was more or less the same. The hypertension was more or less the same. And they did not have any significant adverse events compared to ESAs. This is another study which looked at the patients with CKD. This is from the Dr. Sanjeev Gulati's group. So they had 517 CKD patients, means who were on dialysis as well as non-dialysis. So irrespective of whether they were on dialysis or off dialysis, they had good improvement in hemoglobin. But pre-dialysis patients had a better hemoglobin response compared to those who were on dialysis. So this is from our own patients. So this fellow was a CKD since 2018, lost follow-up, came in 2013. So he initially the jump is due to the blood transfusion. However, there was no response earlier despite maximal hemoglobin. He had severe diabetic retinopathy, so we did not give HIF PHIs initially, but then later he came and demanded because he saw a rise in hemoglobin, and all the dialysis patients keep on talking to each other. So he came and wanted the tablet. So we started him on Desidustat somewhere over here in August 2024. So this is what you see, a sudden jump in hemoglobin from around 9 to 12, 12.7. So we had to stop. So after that, it has been maintaining around that level. But this is what is a nightmare for us, a hemoglobin shooting beyond 12. So we have to be careful. We have to do weekly hemoglobin so that their hemoglobin doesn't go up. So this is another person who has been on dialysis with us. Initially his hemoglobin was on the lower side, and this is one of our first patients who we started on Desidustat. So we started him on Desidustat in somewhere in June 2022, and after that his hemoglobin has been quite stable. It has been in the 10 to 12 range in the majority of times. So the take-home points are it is as good if not better than other ESAs. but sometimes we see a very rapid response. So you have seen that there is a rapid response from 9 to 12. And whether to start low, whether you start at a lower dose and go up slowly, or whether to go up with a full blast. So it depends on the physician's style. So I think we can have a discussion on how everyone's style regarding Desi-Desidustat is. So the other thing is, again, people are skeptical whether Desi-Desidustat alone can do the job or whether you need to combine with erythropoietin. So Desi-Desidustat basically acts by increasing the endogenous erythropoietin production. So there is no need at all to administer exogenous erythropoietin, because administering exogenous erythropoietin and when you add Desi-Desidustat, quite often there can be a very rapid rise in hemoglobin. So none of the guidelines and even the product monograph and even the developers, they do not advocate adding erythropoietin to Desi-Desidustat. Desi-Desidustat alone does the job majority of the times. So another controversy is, can we use Desi-Desidustat in polycystic kidney disease? So Desi-Desidustat, what it does is it enhances the proliferation of endothelial colony forming cells. It increases the chloride dependent fluid secretion in cysts, and it is not recommended for use, but in certain cases you can use the Desi-Desidustat in PKD, but you need to monitor the cyst sizes, and the patient should be on regular follow-up. Access thrombosis is another issue. So this mainly happened with the roxadustat, because when they compared it with placebo, the access thrombosis was much higher. But when you compare it with erythropoietin, it was not much. But there was an increase in the thrombosis and vascular calcification. So daprodustat is another molecule which had another increase in the vascular calcification. So this is because it stimulates the RUNX2 gene. Desi-Desidustat, there is no data whether it causes an increase in the vascular thrombosis or not, but from our experience, there does not seem to be any significant increase compared to erythropoietin or darbepoietin. In fact, we see more thrombosis with darbepoietin than compared to EPO or Desi-Desidustat. So this is another interesting factor, if PHIs and the heart. So this is a analysis from 2021. So they pulled three pivotal phase 3 trials having about 1,530 patients. So as we all know, Desi-Desidustat performed better compared to erythropoietin, but this was which was very interesting. So they found that there was a 30% reduction in the MACE events. There was a 34% lower incidence of MACE plus events, and there was a 24% lower incidence of all-cause mortality when you compare with the erythropoietin alpha. This was too rosy to be true, so they looked back at the trials again. So they found out that they had the results. So a fantastic molecule means given a very rosy results because they cooked up to prove the trial. So ultimately, FDA kicked roxadustat out of the market in 2021. And this was a meta-analysis in 2024. So they looked at all the trials regarding roxadustat, and what they found out that the picture was not rosy, but it was not as bad as it was perceived to be by the FDA. In fact, the incidence of MACE was only 13% in the roxadustat arm, where it was 17% in the ESA arm. Heart failure was lesser, and even death was less in the roxadustat arm. But even now, it is. I don't think it has been granted license in the US. His PHIs, they have got much more pleiotropic benefits, means in heart, though it was supposed to increase the MACE events, that is not so. In diabetic cardiomyopathy, it has got benefits. So how the adult heart functions is about 70% of energy is given by the mitochondrial oxidation and 30% by fatty acids by the glucose oxidation. In diabetes mellitus, there's a reduction in the GLUT4 in the heart, so the glucose doesn't enter into the myocyte. So what this HIF-PHI does is, it improves the glucogenolysis and improves the fatty acid oxidation. So there is an increased energy which is available for the heart, and it also reduces the reactive oxygen species. And by lieu of the increased VEGF production, there is an increase in the myocardial vessel, so the perfusion also improves. So what they say is it is very beneficial for diabetic cardiomyopathy. So you look at diabetic kidney disease, again, because of the reactive oxygen species, there is a reduction in the renal cell apoptosis. Also, it has been shown to be of use in ischemia reperfusion injuries. And after roxadustat treatment, it alleviates the AKI and inflammation inside the kidney. So these are all in animal trials. We don't have real world data in humans. So peripheral vascular disease, one of the mechanisms why diabetic wounds don't heal is reduction in VEGF. Because there is an increase in the VEGF, wounds heal far better in patients who are on HIF-PHI inhibitors. So there are no RCTs, but these are all observational and animal data. So if you look at the diabetic retinopathy and retinal detachment, again, there are conflicting data. Because of the increased VEGF, it can cause a worsening of the diabetic retinopathy theoretically. But with Roxadustat, we have not seen much worsening of a diabetic retinopathy. And the retinal detachment, there is a beneficial role because by reduction of reactive oxygen species and upregulation of BNIP3G, it protects the photoreceptors from apoptosis and tissue damage. So it helps in preventing the loss of vision and retinal detachment. And roxadustat has got a role in the retinopathy of prematurity because of HIF1 stabilization. So that is another pleiotropic effect. And this is what they looked at when they put the patients in pre-diabetic patients. So there was an improvement in anemia, and this is the patient survival and incidence of dialysis initiation. So what they found out that there was a lower incidence of dialysis initiation and mortality in HIF-PHI group over a median follow-up. So maybe we can put more patients on HIF-PHIs and have our own data. So there are newer horizons. So this is from the 2026 Indian Journal of Nephrology. So they looked at use of Desi-Desidustat in biosimilar erythropoietin preparation induced pure cell, red cell aplasia. So there were 14 patients, and the majority had received multiple blood transfusions, a median of 9 transfusions. So they started the patients on Desi-Desidustat, ranging from 100 milligrams thrice a week to 100 milligrams daily. So what they found out that in the 9 out of 12 patients, they were able to achieve transfusion independence, and a lot of them achieved a hemoglobin of more than 12. So only 3 patients remain transfusion dependent, and it is a very encouraging paper. So this is another paper, which showed that it is effective in patients who had in a patient who had severe post-transplant anemia due to parvovirus V19 infection. And Desidustat secured the FDA orphan drug status for sickle cell therapy. So this is because there's an increased pyruvate kinase activity by the HIF-PHI inhibitors, and there is a reduced sickling. So it is useful in sickle cell anemia. And it has been used in people who have got off-label in patients who have got autoimmune hemolytic anemia and beta thalassemia, and it has been found to be useful.
Suraj sir,
So
can you wind up?
yeah, sure. So this is what we have seen earlier. So before prescribing all this, but we don't have data that Desidustat causes or worsens all this, and we can use all this in people with on a case-to-case basis. And the advantages are it is oral, there is no need for pricks. It has been shown to increase hemoglobin, reduces the cholesterol, regulates hepcidin, etc. And the subgroups that can benefit most from Desidustat are patients with inflammation, chronic disease, those who are ESA hyporesponsive, and those who have got functional iron deficiency, that is normal to high ferritin and low TSAT. So in these patients, we can use Desidustat, and those patients who are who have a fear of prick. So Desidustat is a very beautiful molecule. We are yet to see the full potential of Desidustat, and so far the journey has been good. So thank you, Martin.
Thank
So
you,
thank you
sir.
for a patient listening. Yeah.